Welcome back everybody, David here again with Med School Bootcamp. So in this video, we're going to talk about squamous cell carcinoma of the bladder. So if you were following along, you recall that in the last series, we said that the transitional cell carcinoma or the urothelial cell carcinoma of the bladder was the common one. It's very common in the bladder. It can occur in other places. Squamous cell carcinoma can also occur in the bladder. However, it's much more rare compared to urothelial cell carcinoma. So when we talk about the etiology here, the main point I want you to take from this video that this is due to chronic bladder irritation. So something that is a sustained effect on the bladder over time is most likely to lead to squamous cell carcinoma. The risk factors here you're going to notice are very similar, but I'll point out the key one I want you to know for test taking purposes. So smoking, we know, chronic things like cystitis, chronic nephrolithiasis or kidney stones, but the key one I want you to keep in mind for test taking purposes is right here. This is an infection or a bug called Schistosoma hematobium, and this is typically found in Africa or the Middle East. And they'll often give you this in the question stem. If they want you to be thinking about this type of parasitic infection, they're going to give you the geographic location that the patient is either visiting from or they live in or whatever it is. And commonly for board questions, test taking purposes, they're going to give you one of these two different locations. Now, when we move on to our presentation here, really consistent with a lot of other urinary pathologies, right? The painless hematuria. Why, if you recall from the last video, is it painless? That's right, because I want you to associate painless with malignancy. Painful we associate with other things such as nephrolithiasis, maybe some glomerulonephropathies, but painless for test-taking purposes associate with malignancy until proven otherwise. In clinical practice, it can present in a variety of different ways, but it's a good way to kind of build your differential to think about what's the most likely based on the patient's presentation. You can also get some other symptoms, including urinary frequency, urgency, or dysuria. However, these are fairly nonspecific because we know we can see these in a lot of other things or pathologies of the urinary tract system. So when we're thinking about building our differential here, patients will commonly present with hematuria plus flank pain. And when you see this, we have to differentiate some things. Is this painful or painless hematuria? Are there red blood cell casts? Are there systemic signs or symptoms? As well as the location of the patient's pain. Is it lower abdominal pain? Is it more likely to be in the bladder? Could we be dealing with a cystitis potentially? Or is it higher up, right? Is it flank pain? Do they have the CVA tenderness? Are we dealing with pyelonephritis? Are we dealing with kidney stones? If we're talking about our hematuria, right, if it's painful, think of kidney stones. If it's painless, think of malignancy. If we have red blood cell cast, we're thinking of what? That's right, glomerulonephritis or glomerulonephropathies. And likewise, if we're having systemic signs, we're thinking that the infection, right, or what's going on is higher up in the urinary tract system. We could also be dealing with vasculitides at this point, including lupus or IgA vasculitis. And finally, we want to consider the location. Like I said, is this lower abdominal? Is this upper abdominal? Flank? CVA tenderness, what's going on with this patient's symptoms? Typically in malignancy, the patients aren't necessarily feeling pain. They're not necessarily saying they have abdominal pain. They're typically saying they have a new onset of blood in their urine that's concerning and they want to get it checked out. They may have some additional symptoms and findings such as dysuria or urinary frequency. However, this is not present for every patient. So as you're getting these clues, right, and you're working through a patient presentation in the question stems, start to build your differential. What age range are we talking about? What are their risk factors? What are their vital signs looking like? What are their workplace exposures? Where do they live? Things like that. You want to use everything you can to determine what's the most likely answer for the question that you're being asked. Now, going back to our diagnostics here, same things apply as with most. We would do a urinalysis first, which is going to show us hematuria, and we're not going to see red blood cell cast. For a similar reason as we said in the previous video, which is that this is typically of bladder origin, right? Red blood cell casts are more likely to be associated with things from glomerular origin. So we would not expect to see that in this patient. Additionally, you could get the same imaging that we got in the previous video, which can include a CT or a cystoscopy with a biopsy, as these can provide you more information on the patient's condition. Now, finally, we're going to talk about management options, very, very similar to the previous video. Again, if there is bladder carcinoma that does not invade the smooth muscle without smooth muscle invasion, we're going to do the transurethral resection of the bladder tumor. And if it does invade the smooth muscle, we're going to consider the radical cystectomy. Again, very similar to the previous video in which we talked about it in a little bit more depth, but the treatment options are going to more or less be the same because we're still dealing with a carcinoma of the bladder, albeit in this one, it is just of a different origin. We're dealing with squamous cell carcinoma versus urothelial cell carcinoma. So a classic vignette for this is going to present really similarly to other types of bladder cancers, right? It's typically going to be an elderly patient, oftentimes they'll have a smoking history, but if they're trying to get at squamous cell carcinoma, really, they're going to talk about this parasitic infection right here. They might talk about these locations right here. So if you see this parasite listed in the question stem, I want you to be thinking about this type of bladder cancer because this is a common association they will make in test questions. Presentation here is going to be fairly generic for what we would expect to see in any kind of urinary problem. However, we're going to highlight the painless hematuria, and we're going to contrast that with things that would cause painful hematuria. Painless we associate with malignancy. When we talk about our diagnostics, similar things as before, a urinalysis and some imaging is going to be useful to further work up this patient and likely confirm the diagnosis. And when we talk about management options, it's going to come down to location, location, location. Is this contained within the bladder? Can we do a smaller procedure, such as a transurethral resection of the bladder tumor? Or do we need to remove the whole thing in its entirety because we have invasion of the smooth muscle, in which case we would need to do a radical cystectomy?